Good morning, students. Today, we will cover about one of the superficial fungal infections of the skin, Pytyriasis versicolor and cutaneous candidiasis. Before that, I'll myself, Dr. Indradevi, Professor and HOD of DVL department in this college. Pytyriasis means other name for Pytyriasis versicolor is Tinea versicolor. That was previously used. Nowadays, the terminology has been replaced by Pytyriasis versicolor. Literal meaning for Pytyriasis means brown-like. Versicolor means different colors. It is one of the superficial fungal infection of the skin caused by lipophilic yeast Malassezia species. So many species are under Malassezia. Malassezia globosa, furfur, restricta, nana, symphodialis, sloophy, pachydermatitis, dermatitis, japonica. Among the so many species, Malassezia globosa is the commonest one. Usually it occurs in adults and age group and adults, where in this age group only sebaceous activity is more, leading on to this commensal organism becoming pathogenic. What is the pathogenesis behind Pytyriasis versicolor is, this is the normal commensal yeast become pathogenic under certain predisposing condition. What are the conditions predisposing to the infection of this organism, commensal organisms are warm and humid climate, Cushing's disease or syndrome, any hyperhidrosis condition, malnourished status, immunosuppression, oral contraceptive use. How the clinical morphology of the lesion will look like now? This is in Tamil, we will be calling it as Temal, Alukku Temal. It's not due to dirt, it is due to superficial fungal infection. It's how the clinical morphology is well-defined hypopigmented macule. The borders are as if marked by a pencil, covered with brawny scales. Distributed, the area of distribution, since it is a lipophilic fungus, it is in the sebum secreting areas of the face, upper chest, upper back, and abdomen. The sign what we can elicit in this condition is Cudi angle sign or fingernail sign or stroke the nail sign. When we stroke the lesion, scales are removed en masse. This is known as Cudi angle sign or stroke the nail sign or fingernail sign. This is the classical morphology of the lesion. As I already told you, different types of morphology, different colors. But how the lesions will be now? Well-defined, hypopigmented or hyperpigmented, well-defined hypo or hyperpigmented macules, as if borders are as if marked by a pencil, covered with brawny scales, The outer layer of rice, we will be calling it as brawny scales. What are the reasons for hypopigmentation? So many reasons they are telling. Among the reasons and the commonest cause for hypopigmentation is this: the Malassezia species will secrete one dicarboxylic acid, that is azelaic acid, which is the competitive inhibitor of the enzyme tyrosinase, which once again is the rate limiting enzyme in the synthesis of melanin. Obviously, the melanin synthesis is impaired, leading on to hypopigmentation of the clinical picture. Then production of micromelanosomes. Third cause is the brown-like sunscreening effect of brown-like scales. There is one chemical called pityriacitrin secreted by the Malassezia species, absorbs the UV radiation, leading on to hypopigmentation. Another proposed hypothesis for the hypopigmentation is defect in the transfer of melanin from the melanosomes to the keratinocytes. Then finally, production of micromelanosomes. This hypopigmented variety is otherwise known as achromic type. Hyperpigmented variety is known as chromic type. The reason for chromic Pytyriasis versicolors are hyperkeratosis, and production of macromelanosomes. Various differential diagnoses for the chromic pityriasis versicolor. One of the commonest differential diagnoses is erythrasma. It is caused by bacterial infection. Corynebacterium minutissimum is the causative organism for the condition erythrasma, which is characterized clinically by sharply demarcated, dry brown, slightly scaly patches, absolutely asymptomatic condition, common in obese individuals in the flexural areas. Erythrasma is the commonest differential diagnosis for hyperpigmented type of pityriasis versicolor or chromic pityriasis versicolor. This is the classical morphology of hypopigmented pityriasis versicolor or achromic type. Various differential diagnoses are, one among them is vitiligo. Here the patch is, this is typical of vitiligo patch. Here the patch is on the depigmented patch. Here is hypopigmented. Here the depigmented patch and also there is no scaling and no sensory loss. Next closest differential diagnosis for hypopigmented pityriasis versicolor is Pytyriasis alba. Excuse me. Yeah, where it is characterized, usually common in children. It is one of the type of endogenous eczema characterized clinically by hypopigmented macules and patch, usually on the face and the limbs, ill-defined borders. Where in pityriasis versicolor, borders are marked by a pencil, well-defined borders. Here, ill-defined borders, no sensory changes, non-fluorescent under microscope. Next differential diagnosis is indeterminate answer. These are the differential diagnosis for hypopigmented type of pityriasis versicolor. Indeterminate leprosy is common in children, where characterized clinically by ill-defined hypopigmented patch without surface changes. Sensation may or may not be impaired. Another one differential diagnosis is borderline tuberculoid Hansen, characterized clinically by hypopigmented patch, ill to well-defined patch. Satellite lesion will be there in case of borderline tuberculoid Hansen. This is one of the another hypopigmented pityriasis versicolor differential diagnosis. This clinical condition is known as polymorphic light eruption. It is common in the sun-exposed area. Clinically, hypopigmented lesion, either asymptomatic or slightly itching over the photo-exposed areas. This is another one genetic condition called nevus anemicus. It's a type of mole present since birth, where there is a clinically characterized by hypopigmented macules or patch covered with well-defined border. There is no scaling, and there is one test called taking a clean glass light, pressing under the lesion, it will blanch. This is known as diascopic test to differentiate between nevus anemicus and another one condition called nevus achromicus. This is typical of post-inflammatory hyperpigmentation. Previously, some inflammatory pathology might be the psoriasis, eczema, syphilis, yaws, like an lupus erythematosus, or due to long-term use of steroids, the lesions are being modified, leading on to post-inflammatory hyperpigmentation. It's one of the differential diagnosis for hypopigmented type of pityriasis versicolor. So far, we have seen about one of the superficial fungal infection called pityriasis versicolor. Clinically itself, we can diagnose. This is the classical clinical picture of pityriasis versicolor. This can be diagnosed clinically itself. We can diagnose. If at all any doubt now, we can scrape the lesion, put it under a clean glass light, and add a drop of 10% KOH. We can see typical morphology of the under the slide KOH mount. What is that now? Arrangement we will be calling it as spores and hyphae are arranged like banana and grapes are spaghetti and meatball appearance. Banana and grapes are spaghetti and meatball appearance. If at all any doubt now, we can do fungal culture with SDA agar, Sabros dextrose agar. Since it is a lipophilic fungus, to the agar medium, we have to add olive oil. The cosmetic purpose only, the patient will be visiting to our OPD. If you want to treat the patient now, we have to counsel the patient. The discoloration might be taking minimum 1 month to subside, even though organism will die off with 1 dose of any antifungals. Usually in our OPD, we used to give azoles. Prototype example for antifungal azole வந்து fluconazole. We are giving on the start dose of fluconazole 400 milligram. It is the pulse therapy for Pytyriasis versicolor, and also topically we have to give miconazole gel and ketoconazole creams at night time, and also we have to give them instructions regarding keep the area dry, avoid oil bathing, loose fitting cotton dresses, and avoid one day they have to drink hydration to be maintained, plenty of oral fluids, and wearing some cotton cloths during summer time. And we can advise them to dusting powder also while going out in the hot sunlight. These are the treatment option for Pytyriasis versicolor. Once again, I will summarize. Pytyriasis versicolor is nothing but one of the superficial fungal infection of the skin. Causative organism, Malassezia species. So many organisms under Malassezia species. Among them, commonest one is Globosa. Other things and all, Furfur, Restricta, Nana, Sloofy, Symphodialis, Japanicum, Restricta, and then Pachydermatitis. Among the so many species, and the clinically how the morphology na either hyperpigmented or hypopigmented, well-defined macules or patches in the sebum secreting area of the face, upper chest, upper back. Clinically itself, we can come to a conclusion. If any doubt not, 10% KOH mount, we can see under the microscope spores and hyphae. And the arrangement, we will be calling it as spaghetti and meatball appearance or banana and grape appearance. If any doubt now, we can do fungal culture with Sabras dextrose agar with olive oil. Treatment purpose and the best drug for this one, the azole antifungals. Topically, when we can give miconazole or eberconazole. So many azoles are there in topicals, starting from clotrimazoles, miconazole, iconazole, sulciconazole, oxyconazole, cetraconazole. So whichever you want to give, you can give. And also they tell them to avoid on the oil bathing frequently. Next, we'll go for another superficial fungal infection, cutaneous candidiasis. Candidiasis, other name for candidiasis is moniliasis, an infection caused by Candida species. It is the normal commensal of the mouth, gastrointestinal tract, and vagina. It is a yeast. It produces budding cells, pseudo-hyphae. Hyphae are produced only during tissue invasion. There are more than 150 species in the genus Candida, but only few species affect human beings. Among them, and the commonest one and the Candida albicans, Candida tropicalis, Candida parapsilosis, cruzi, glabrota, Guillermandi, dubliensis, tropicalis, pseudotropicalis. So many. You should remember and at UG level, Candida albicans, important one. It's a yeast fungus. It becomes, what are the basic pathogenesis for cutaneous candidiasis is, to become pathogenic, the yeast form should transform into the invasive mycelial form under the certain predisposing factor. Main commonest predisposing factor is obesity, moist environment, diabetes mellitus, immunosuppression in the form of organ transplantation or infections such as HIV infection, wet work atmosphere, or use of broad spectrum antibiotics, and even pregnancy can precipitate this infection. Clinically, it infects only the outer layers of the skin, the mucous membrane. Primary lesions is either a papule or a pustule, later become a raw eroded glistening erythema with undermined fringe advancing margin. So many clinical types for candidiasis. One is flexural candidiasis, otherwise known as candidial intertrigo, where there is involvement of the skin fold flexural areas, commonly axilla, groin, inframammary area, retroauricular folds, web spaces, gluteal folds. Characterized clinically by itchy rest, moist glistening surface with sharply defined advancing margin, which has an undermined fringe of macerator scale, surrounded by satellite papules or pustules. This is the typical clear picture of flexural candidiasis. Red, moist, glistening surface surrounded by the advancing border. One of the clinical type of cutaneous candidiasis. This is flexural candidiasis or candidial intertrigo. Intertrigo is nothing but infection or inflammation of the two opposing body surface area. If it is due to candidiasis, we will be calling it as candidial intertrigo. This is the intertrigo of the web spaces. The name given for the finger web spaces, candidial intertrigo of the finger web spaces is Erosio interdigitalis blastomycetica. Erosio interdigitalis blastomycetica is the name for the intertrigo of the web spaces by Candida species. This is typical in children where the erythema of Jacquet, one of the clinical type of cutaneous candidiasis, characterized clinically by superficial painful erosion persisting for a longer time. This is known as erythema of Jacquet. Differential diagnosis for flexural candidiasis is commonly another one superficial fungal infection called dermatophytic infection. Dermatophytic infection of the crural fold, we will be calling it as tinea cruris, characteristic circinate or broken margin with the central clearing in case of tinea cruris. Tinea cruris, this is the classical morphology of tinea cruris, characterized clinically by a plaque, circumscribed plaque with central clearing, peripheral advancing margins will be there. Another one differential diagnosis for flexural candidiasis is seborrheic intertrigo, characterized clinically by yellowish, greasy and adherent scales with a simultaneous involvement of other sebum secreting area. This is another one on the flexural psoriasis. Psoriasis is nothing but it's a papulos, one of the papuloscomus disorder, characterized clinically by erythematous plaque covered with silvery white scale. But in skin flexural psoriasis, we won't be able to appreciate much scaling, and there is no satellite lesion in case of flexural psoriasis. Another one clinical type of cutaneous candidiasis, one what we are seeing is flexural candidiasis or candidial intertrigo. Commonest differential diagnosis is tinea cruris, seborrheic intertrigo. The next cutaneous clinical morphology of cutaneous candidiasis is candidial paronychia. Onychia means nail, paronychia means involvement of the nail fold. We will call it as paronychia. If it is due to candidiasis means candidial paronychia. Boggy swelling of the nail folds producing occasional bead of thin pus, and there is loss of cuticle in case of candidial paronychia. This is the nail fold inflammation, swelling of the nail fold. We will calling it as Olster sign. Then there is loss of cuticle, secondary nail changes in this case. Nail fold involvement and then loss of cuticle. There is another one condition called onychomycosis. Onychomycosis is nothing but fungal infection, dermatophytic infection, or non-dermatophytic molds also causes the nail plate infection. We will be calling it as onychomycosis. Paronychia is nail fold inflammation or infection. If it is due to candidiasis, candidial paronychia, there will be obviously the loss of cuticle in case of in this patient. Third clinical type of cutaneous candidiasis is napkin candidiasis, characterized clinically by erythema, edema, and fringed irregular border satellite lesion, common in infants or children. Differential diagnosis for napkin candidiasis is napkin dermatitis or irritant contact dermatitis. Napkin dermatitis involves the convexity of the gluteal folds, lower abdomen and gluteal region. At the site of contact with the napkin area will be usually napkin dermatitis spars the inguinal fold. Only at the convexities of the thigh regions are involved in case of napkin. This is napkin dermatitis, but this one is inguinal folds are involved in case of napkin candidiasis. Candidial vulvovaginitis is one of the cutaneous manifestation of cutaneous candidiasis. Most common cause for vaginal discharge, usually seen in 1/4 of the woman in the childbearing age, characterized by curdy white precipitate at the, it's an abnormal vaginal discharge characterized clinically by curdy white precipitate at the vulval outlet. Clinically, symptoms may be vulval itching, irritation, dyspareunia, or creamy discharge. Only just discharge is the main symptom. This is the typical clinical morphology of the Candidial vulvovaginitis. Vulvovaginitis. It's a curdy white precipitate at the introitus. Another one clinical type is Candidial balanoposthitis. Two clinical patterns are there in Candidial balanoposthitis. Balano means glands, posthitis means prefusial sac, itis means inflammation. Inflammation of the glands, penis, and the prefusial sac by Candida, we will be calling it as Candidial balanoposthitis. It's the commonest type seen in diabetic individual and also in normal individual, partner having diabetes also. The two clinical types are there in case of Candidial balanoposthitis, directly due to infection with the Candida albicans or due to hypersensitivity reaction to cutaneous Candida albicans species. Directly invasion and clinically characterized by small papules or papulopustules on the glans penis or in the coronal sulcus. Superficial erythematous erosion with colorate of whitish scale or thrush-like membrane will be there. Profusial edema will be there, later going in for phimosis. This is the typical clinical photograph of the Candidial balanoposthitis. Another one clinical type of Candidial balanoposthitis is due to hypersensitive reaction to Candida albicans species. Clinically, transient erythema and burning following contact with the partner, whoever having the Candidial vaginitis. Another one clinical type is Candidial miliaria or decubital candidiasis. Usually affects the back of the bedridden patient, characterized clinically by Versicolor pustules on an erythematous base. Another clinical type is congenital cutaneous candidiasis, characterized by discrete vesicles and pustules on an erythematous base, presence within first 6 days of life, represents established candidiasis of the skin and birth membranes at birth following intrauterine infection. This is the typical photograph of the congenital cutaneous candidiasis. Risk factor for this condition is prematurity, presence of an intrauterine foreign body, no skin involvement, site face, scalp, fingernails, trunk, leg. This no skin involvement, what I told is for acquired systemic candidiasis, but congenital cutaneous candidiasis primarily affect the skin involvement. Skin is involved, but another one is acquired systemic candidiasis where there is no skin involvement. Another one clinical type is Candidial granuloma. It's usually seen in children, characterized clinically by vascularized papules or nodules covered with a thick adherent yellowish brown crust. This is granulomatous candidiasis of the napkin area. Another one is this is the candidial granuloma. These are the various photographs of the cutaneous candidiasis. One is flexural candidiasis or candidial intertrigo. This is napkin candidiasis. This is oral candidiasis, commonest in bottle-fed infants. This is oral thrush, common morphology. This morphology, other name for oral candidiasis is oral thrush, otherwise known as acute pseudomembranous candidiasis. Acute pseudomembranous candidiasis characterized clinically by curdy white patches or cotton cheese plaque covered by a pseudomembrane over the gums, teeth, or cheek. On removal, the membrane reveals an erythematous base. Chronic pseudomembranous type similar to the acute one, but more persistent one. Another clinical type for the oral candidiasis is median rhomboid glossitis. Dorsum of the tongue shows a diamond area where there is loss of papillae will be seen. Another one clinical type of oral candidiasis is acute atrophic type. Denuded atrophic inflamed membrane on the dorsum of the tongue, pain present. Chronic hyperplastic type is the another morphology of the oral candidiasis, where there is characterized clinically by very persistent, firm, irregular white plaque over the cheek or tongue surrounded by an erythematous margin. It is difficult to scrape that lesion. Commonest differential diagnosis for a chronic hyperplastic type of oral candidiasis is oral airy leukoplakia. It's causative organism Epstein-Barr virus, where there is transverse corrugations or airy appearance on the side of the tongue will be seen. This is a typical picture for oral airy leukoplakia. This one is the chronic hyperplastic type of oral candidiasis. Another last clinical type of oral candidiasis is chronic atrophic candidiasis, characterized by dusky red, sharply defined patch at the denture margins. This is known as perlage or angular cheilitis, where there is characterized clinically by erythema, maceration, fissuring or soreness at the angle of mouth. Last clinical type for cutaneous candidiasis is chronic mucocutaneous candidiasis. It is a syndrome characterized by recurrent and persistent candidial infection of the skin, nail, and mucous membrane. Chronic mucocutaneous, this is the typical photograph of the chronic mucocutaneous candidiasis. These are the various clinical types of, this is oral candidiasis, clinical type, photographs for cutaneous candidiasis. One first picture depicts the oral candidiasis, that is acute pseudomembranous type. This is and Candidial Vulvovaginitis. This is Candidial intertrigo. Third picture shows the Candidial intertrigo. Fourth picture is Candidial Paronychia. Paronychia means inflammation of the nail fold. How to prevent this? Most of the fungal infections, first and foremost is we have to give advice to the patients. Keep that area clean, dry, and then avoid moisture content. Wearing of cotton clothing during summer season. Dusting powder advice must be given to the patients regarding wearing of the clean, dry clothes and avoid when the moisture content. Oil bathing also to be avoided in case of this one. Candidiasis, clinical itself we can diagnose. If at all any doubt now, we can do 10% KOH mount and we see pseudo-hyphae under the microscope. Then we can treat the patient with topically itself. If systemic need, we can go for azoles antifungal. As I already told for Pytyriasis versicolor, azoles antifungal, so many topical applications are there, starting from clotrimazole, miconazole, iconazole, Cetraconazole, nowadays on the Laliconazole, so many things are there. Whichever needed, you can, depending upon the patient's age and then affordability, we can prescribe the topical antifungal. If needed, now we have to go in for systemic. The drug of choice for Candidiasis is fluconazole, 150 milligrams start dose. But in case of Pytyriasis versicolor, we have to give pulse therapy of fluconazole 400 milligrams start dose. Thank you. What to share?